There you go, Liz. I'll record it for you. That just means it won't be on the test. Good. I don't think we talked about that, Ray.
Did we? We did?
It's also in the book. It's actually in Egan. Snow season's coming up, and you'll put Egan back in your trunk so it's weights down the car. Unless you got front wheel drive, and then you're really screwed. It's going to try to reabsorb hydrogen ions and allow potassium ions to go on out. It's the hypochloremic alkalosis that you end up seeing. Your face is just kind of like, what? Is this in Chinese? The lung doesn't have an acidic tubule. Very good. The blood gas whisperer. I just said it, not 10 seconds ago. Show off. Okay, renal failure. Remember, there's 3 primary functions of the kidney. Well, in renal failure, they don't work. There you go. Yeah. Because you end up having bicarb being reabsorbed instead of chloride with hypochloremia. A week from Thursday, we'll cover it again. You'll see it. I won't be here, but Mary will cover it. So, kidneys filtering waste, regulate fluids, regulate electrolyte levels. If that isn't working, obviously those aren't going to be regulated well. It generally is caused by a reduction in glomerular filtration rate. And what you end up seeing is the inability to clear two of the primary waste products, urea and creatinine, so your BUN and your creatinine levels will rise. It can be acute, as in over a few days, or chronic, and again, the chronic is the chronic renal failure that would require persistent dialysis. There is what is called the rifle classification. You guys can memorize this, right? Sure. No, I'm kidding. Just realize that there is a way to evaluate, based upon some clinical measurements, where you're at going from risk to end-stage disease. So it's like COPD, where we use the FEV1 degradation. It's like asthma, where we're looking at symptoms to look at severity. Same thing here. And you can see that a lot of it deals with that creatinine level, as well as the glomerular filtration rate and the urine output. Leave it at that. There's a way to scale it. I don't care that you really know. I do want you to know that there's three types of renal failure: pre-renal, post-renal, and I guess frank renal failure. Not that Frank has renal failure, but you get the idea. Pre-renal would be something where you end up having normal glomerular filtration. It's nothing wrong with the kidney per se. It's the fact that there's not enough blood flow coming to the kidney. So if I don't have adequate volume within the system, I'm obviously not going to be able to have adequate amount of glomerular filtration rate in eventually urine. Sometimes it could be caused by a pre-renal obstruction, something where one of the renal arteries have damage to them, but more often than not, it's hypovolemia as the cause. And so long as you treat the kidney, treat the kidney, stabilize the kidney, there's really not any problems with it. And when we're looking at the urine actually is what we would expect to see. Normal urine osmolarity is something greater than 500 to 800 roughly. That plasma BUN to creatinine ratio is normally about 20 to 1. So the urine that is being produced is what you would expect to see from somebody who's healthy. It's just that the overall volume of urine you're seeing is reduced because it's just not being perfused. So this might be something that we might have patient coming into the ER, coming in from a nursing home, hasn't been well hydrated. They're going to have a reduced urine output, but the urine that is there is what you would expect to see from a normal person. Okay, and you should know the normal BUN and creatinine. I don't know if you've gotten exposed to that much in the ICU, but those are the normal values we're going to go with. And you can see that it's about a 20 to 1 ratio that you end up having. Post-renal failure is after the kidney, and again, this is assuming a normal kidney, but just something downstream, kidney stones, for instance, causing an obstruction, bladder dysfunction, prostate cancer, where the prostate is enlarged and compressing on the bladder in men. But those are all things that are quite reversible. Find out where the obstruction is, fix the obstruction, and the kidney will return to normal once that's done. Okay. But those aren't the ones that we normally encounter. We normally encounter this one, where you truly have damage to the nephron itself and its ability to function as far as removing water or regulating water, regulating electrolyte balance, and removing waste products. Multiple causes for this, just simply having hypertension, diabetes, damage to the vasculature itself will cause damage to the nephron. There can actually be an inflammatory process of the glomerulus called glomerulonephritis. Many times we see the acute tubular necrosis and a post-cardiac arrest. Reduced blood flow, reduced oxygen supply to the kidney as a whole. The nephron becomes ineffective, and we end up calling that ATN in the process. In that case, now you're starting to have a very unconcentrated, a very dilute urine being produced, and that BUN to creatinine ratio becomes much lower. So this is the renal failure that we see in the ICU that we're going to have to dialyze. Okay? Enough of the renal failure, enough of the kidneys. Let's talk diuretics, because I know it's one of my favorite topics.
Rick, you're going to get the same volume of urine? It's going to be dilute?
No, volume will be down considerably, but it's going to be a very dilute urine. Because a lot of the waste products, the BUN and creatinine, which are pretty large molecular structures, don't get passed out. They just remain inside the bloodstream.
Post-renal failure, urine output will go down, but the concentration.
Correct. It's normal. So we're going to talk a little bit about diuretics, and I'll point out what I want you to know related to this. But we'll also talk about the renin-angiotensin-aldosterone ADH process and how they affect. We use diuretics basically to regulate the water and, in essence, the sodium levels within the body. Multiple reasons that we end up seeing that being utilized. Obviously, in renal failure, it's one of the attempts that we can try to do to try and increase the amount of fluid that is present. Congestive heart failure. We all remember the horse and the cart analogy, where we try to lighten the load by using diuretics. Chronic hypertension management, part of that is our use of a diuretic. Edema, especially cerebral edema, we can diurese and reduce the swelling. And we don't come across a whole lot of the glaucoma, but diuretics actually can function in that area also. There are 5 types of diuretics working in 5 different areas. So let's talk about them. First one is, and by the way, this is a website that I used for a lot of my drawings, a lot of the pictures that are in here, and a lot of the explanations. It's a great little review on diuretics if you aren't up to speed on them. So this is my glomerulus and my proximal tubule. The first one that is involved here is a carbonic anhydrase inhibitor that inhibits the conversion of CO2 to bicarbonate, and bicarbonate cannot be reabsorbed into the capillaries because of that inhibition of that process. This one works in the proximal tubule, as it shows. The only real example I can think of is acetazolamide or Diamox. And because bicarbonate cannot be reabsorbed, it's allowed to be excreted. So one of the things we used to use this for was somebody who had a profoundly elevated bicarbonate level. In most cases, that bicarbonate level is compensatory to a respiratory acidosis, so I don't know why you would want to treat it with Diamox, but it's really not a diuretic that we utilize in the ICUs at all. Where it is utilized is one of the other places where carbonic anhydrase is utilized is in the eye. So for control of glaucoma, you end up utilizing that. Carbonic anhydrase, proximal tubule, acetazolamide or Diamox. And those are the kind of things that I might ask. Okay? And yes, you do need to know the drugs' names. Okay. Second way, osmotic diuretics. Osmotic diuretics work in the descending loop, and they promote the removal of water into the tubule, or out of the tubules into the capillaries. These are items that are allowed to pass into the glomerulus, but they're not reabsorbed by the peritubular capillaries. The classic one is mannitol. Mannitol is the medication. It basically keeps water in the tubules because it's a big substance. It's not reabsorbed in the proximal tubules. It's allowed to continue down the descending loop. In this case, remember, that's where a lot of that water is reabsorbed, and it prevents that from happening. The classic cases, this is what we would use for increased intracranial pressure. So I have somebody whose ICP is elevated due to a head trauma, swelling. Mannitol is a wonderful drug to diurese them down, yes.
The drug itself works to increase the concentration, or it holds more?
It gets filtered out in the glomerulus, stays in the tubule, and prevents water from moving out of the tubule in that descending loop. Okay? Osmotic, mannitol, head trauma. Fourth one, I'm skipping the third one. I'll come back to it. Fourth one is the thiazides. Thiazides work in the distal tubule. And they work by interfering with the sodium reabsorption that's done. If you remember back, that distal tubule has very small, it's just kind of like the last tapering of sodium reabsorption and water reabsorption. So it's not really a potent diuretic, but it's one that is used as a maintenance drug. Because it's, the side effect is that you can end up having some potassium excretion. Again, not large, but you can end up having hypokalemia as a side effect, and that's quite common. And most people on diuretics are encouraged, on thiazide diuretics, are encouraged to increase their potassium intake, you know, eating bananas and whatever else is high in potassium, kale. There's no way this boy is eating kale, but whatever. I've seen the potato chips, yeah.
Coconut water.
Coconut water? Okay. No thanks. I hate coconut too. So diuryl, hydrodiuryl, hydrochlorothiazide, HCT, those are all examples of thiazide diuretics. Thiazide, distal tubule, might have hypokalemia as a side effect. The one we're most familiar with are the loop diuretics. And the loop diuretics prevent that sodium, remember that's the area where it's impermeable to water following the sodium, so it prevents the sodium from leaving, thereby keeping the water inside the tubule and eventually be excreted as urine. Examples are the ones that you typically see in the ICU, Lasix, Bumex, and they're more potent diuretics than the thiazide. So if the person was on thiazides at home and they come into the ER and CHF, we're going to probably have to go to something a little bit stronger, and that's where you hit them with some Lasix or some Bumex to clear that. Loop diuretics, Lasix, Bumex, Lupa-Henley, yeah, potent. And then finally, there's the potassium-sparing diuretics that if there is a problem, remember if we had a hypochloremic situation, we didn't have enough sodium or chloride in the urine or in the tubule, we would utilize this to use the sodium bicarbonate as the exchange process. And in the face of an acidosis, in the face of an alkalosis in the bloodstream, we're not going to sacrifice hydrogen ions, we're going to sacrifice potassium. So in this case, if we don't have sodium being reabsorbed, we don't have the need to have that bicarbonate, and we don't have the need for the potassium to be excreted, so they spare the loss of potassium ions. And really the only one that you probably will ever come across is, well, I shouldn't say that, but spironolactone, aldactone was the classic example. Amiloride or Mitamor has kind of an interesting effect with asthma. That's a whole separate process.
Should we know the others too?
No, you can just know spironolactone. I'll go with that one. Be nice to you. And lastly, let's talk about the renin-angiotensin system, since I know you all remember this process. This is where, if you go back, we were talking about the juxtaglomerular apparatus. This portion right here, where that distal tubule comes in proximity to the afferent and efferent arteriole near the glomerulus. And what it does is when it senses a reduction in blood flow through those vessels, a reduced blood pressure, renin is going to be released by the kidney. When renin is released, it is converted to angiotensin 1 and further converted to angiotensin 2. That angiotensin 2 then does a whole bunch of different things. This I think I have blown up for you in the back. This would be a really good resource to study from. Is that enough of a hint? So let's track this out and see what happens. I end up having a reduction in renal perfusion. Blood pressure drops. The kidneys sense this as a loss of blood volume. The kidney then goes ahead and releases renin. The liver releases a substance called angiotensin. And the renin, in the presence of angiotensin, forms a substance called angiotensin 1. Angiotensin 1 then passes through the lungs. One of the biological functions of the lungs is it has an enzyme, angiotensin-converting enzyme. Wow, what a novel idea. And the angiotensin-converting enzyme converts angiotensin 1 into angiotensin 2. One of the primary mechanisms by which we control blood pressure is by blocking the conversion of angiotensin 1 into angiotensin 2. These are called ACE inhibitors. This conversion isn't there. All the stuff subsequent to that, including an increase in blood pressure, doesn't happen. There's also a group called ACE2, which allow the conversion to happen, but it blocks it here at the arteriole. It's not really dealing with the kidney, but it helps explain why we have patients on ACE1 or ACE2 inhibitors. So let's say this conversion happens. Angiotensin 2 is now created, does a bunch of things. First of all, it has an increase in sympathetic activity. So just as a generality, it acts like epinephrine. You end up having increase in heart rate, increase in all those sympathetic things. One or the other, we'll go here. Second thing it does is it causes sodium to be reabsorbed back into the capillaries. In the process, it sacrifices potassium, but the extra sodium being reabsorbed leads to more water reabsorption. Third thing it does is let's see, this is 1, 2. Third thing it does is it goes ahead and stimulates the adrenal cortex to produce a hormone called aldosterone. Aldosterone also goes ahead and promotes sodium reabsorption. Fourth thing we mentioned, it goes ahead and has vasoconstriction of the arteriolar wall, increasing blood pressure that way. And the fifth way, this little bugger just gets around and does its duty. But the fifth thing it does is it goes ahead and triggers the pituitary gland to secrete a hormone called antidiuretic hormone, or vasopressin, which acts in the collecting duct. So it acts in that number 5 portion of the kidney to promote water reabsorption. Net effect is that water and sodium are reabsorbed. As that water is reabsorbed, you end up having volume in the vasculature increase, and that perfusion now can be sensed by the juxtaglomerular apparatus. Hey, my blood pressure is back up. I don't need to go ahead and keep secreting renin. And the process stops. Yes, Patricia. They're pills. They're medications. It's one of the more common way we end up. We can do beta blockade. We can do alpha blocking. Primarily, we end up doing ACE inhibitors. That's probably the most common type of antihypertensive agent. Yes. When the blood pressure comes back up. Okay. When the juxtaglomerular apparatus senses the fact that blood flow is now restored.
So ACE inhibitors are in the entire body in 2
No. ACE inhibitors are medications which block this renin-angiotensin system, stop in its tracks so that we don't have hypertension occurring.
So that's a systemic, that's your entire body blood
Yeah,
pressure.
yeah. So if if your parent was hypertensive, one of the ways that we could lower the blood pressure were to be giving ACE1 or ACE2 inhibitors. It's just a common way that we regulate it. It's doing it on the renin-angiotensin system. Go ahead, Patricia.
But doesn't this happen because of the low perfusion fluid?
Yeah, yeah. I probably shouldn't have even talked about ACE inhibitors, should I have?
Why would you block it?
This process normally goes on, and a way to control blood pressure, nothing about the glomerular filtration being reduced, just in general, are these ways. Now I shouldn't even have brought this up. Would have been easier.
The kidney goes down. Bam, this was happening.
I was just showing you where these things work.
That's what you said. How does the chemoreceptors in the other,
The baroreceptors, you mean?
no, that's the piece here.
The peripheral chemoreceptors? Those respond, the peripheral chemoreceptors respond to blood gas changes, pH, PCO2, PO2. No. You might be thinking of the baroreceptors, which are located in the same place, in the carotid artery and in the aortic arch. They respond to a reduced in perfusion pressure and really do the first one more so, just send back impulses to increase arteriolar constriction. Nothing to do with this, though. It just happens to be a parallel pathway to raising blood pressure. Yeah, yeah, yeah. Where we see this happening is when we put a person on mechanical ventilation initially. The increased intrathoracic pressure reduces renal perfusion, so you end up having the body thinking it's got a blood volume loss, so it triggers this system on, when it's really not the case. But okay, this is in your text that I know nobody reads, but it's basically saying what aldosterone ends up doing. Aldosterone causes that reabsorption of sodium, right here, number 3. It also allows for potassium to be excreted, which leads to hypokalemia and a net alkalosis in the process, because I'm also retaining, as I'm reabsorbing sodium, I'm reabsorbing it as bicarbonate, and you may lose hydrogen ions. Certainly you'll lose potassium, and you end up with an alkalotic. The body's attempt, though, is to reabsorb water and ultimately get arterial blood pressure back up. So that's kind of the function of aldosterone. And then finally, I mentioned about ADH, the antidiuretic hormone, also known as vasopressin. That angiotensin II is what stimulates the pituitary gland via the hypothalamus to go ahead and retain water. And it does it through renal reabsorption in that distal tubule, in the collecting duct, and will increase blood volume through that process. It also is a vasopressin itself is a vasoconstrictor. Net effect is that blood pressure is increased. Has anybody been on a code where they're doing obviously CPR, and rather than using epinephrine, they do a dose of vasopressin? Good. Okay. Vasopressin as a medication can be substituted for your regular dose of epinephrine for either the first or the second dose. After that, it doesn't have a whole lot of effect. But you may see vasopressin utilized in the critical care arena. Nothing to do with this. It's more this vasoconstrictive component to it. two asides to this. One is the syndrome of inappropriate ADH secretion, and we see this in patients that have a low sodium because they have just a retention of water. The other one is diabetes insipidus. Same kind of a thing. You end up having, in this case, the pituitary gland is impaired and doesn't secrete antidiuretic hormone, and the exact opposite happens. Instead of retention of water, you just have massive excretion of water, which is why it got the name diabetes, because it kind of looked like diabetes mellitus in having patients that were frequently urinating, very thirsty. Same kind of a picture was placed. Totally different origin of why they have that going on. So that's vasopressin. And I'm glad that this person was around to give us this sage advice. A millionaire is a person who has $1 million.